Welcome to Bio Bits and Bytes. Today we're diving straight into a fascinating and, well, let's be honest, a complex area, fetal tissue transplantation. We've got some really interesting sources for this deep dive research looking at its use in neurodegenerative diseases like Parkinson's, the science behind why it seemed promising, and how it all stacks up against newer stem cell research. Our goal today is really to unpack what fetal tissue transplantation actually is, explore why it generated so much hope for treating some tough conditions, and then see how it compares to things like stem cell therapy, especially for Parkinson's. And to help us navigate all this, we have an expert with us today. So let's start right at the beginning. Could you give us a clear definition? What is fetal tissue transplantation, and why did it initially seem like such a big deal?
Certainly. So fetal tissue transplantation, at its core, it's an experimental procedure. It involves using tissue from aborted human fetuses. And the idea is to replace damaged or non-functioning tissue in patients. Think conditions like Parkinson's disease or type 1 diabetes, where the patient's own tissue isn't doing its job. The initial excitement really came down to a couple of key biological points. First, there's something called immunological compatibility. Basically, it means this tissue is less likely to be rejected by the patient's immune system compared to, say, tissue from an adult donor.
Right.
And second, it has significant growth potential. It can integrate, grow, actually function within the patient's body more effectively.
Okay, let's pause on those terms because they sound really important. Immunological compatibility and growth potential. Can you break those down a bit more for us, specifically in this context? Why fetal tissue?
Absolutely. So immunological compatibility, it's all about how the recipient's immune system reacts, or rather, doesn't react as
Yeah.
strongly. Fetal tissues are still developing, right? They don't have the same high levels of molecules on their surface that scream foreign invader to the immune system.
The triggers.
Exactly. Adult tissues from deceased donors often trigger a really vigorous immune attack. With fetal tissue, that response is typically weaker.
Yeah.
And that means potentially less need for those heavy-duty immunosuppressant drugs, which have their own risks, leaving patients vulnerable to infections.
Makes sense. And the growth potential.
Right. Growth potential, that refers to the built-in ability of these fetal cells to multiply, to develop into specialized cells, and crucially to integrate into the host's tissue.
Mm.
Because they're still developing, they're more adaptable, they can kind of fit into their new environment, form connections, and help with repair in a way that more mature, set in their ways adult cells often can't.
More flexible then.
Precisely.
So, building on that, why was fetal tissue seen as a better shot than using tissue from adult cadavers? You mentioned the immune side, but what else?
Yeah, several other key things. We talked about rejection with adult cadaveric tissue and needing immunosuppressants, but also think about the time between death and getting the tissue the post-mortem interval. That delay can cause cell death, meaning the tissue might just not be viable.
Right, it degrades.
Exactly. It might not integrate well, might not function. Fetal tissues, on the other hand, tend to provoke less of an immune fight, especially if you put them in what we call immunologically privileged sites.
Okay, immunologically privileged sites. That sounds specific. What are those? And maybe could you quickly
Ah.
define lymphocytes for us too? They're the immune cells involved here, right?
Yes, good question. So immunologically privileged sites are basically parts of the body where the immune system is naturally sort of toned down. It's less aggressive. Think places like the brain, the front part of the eye, the testes, parts of the kidney, the uterus. In these spots, foreign tissue, like a fetal graft, has a better chance of survival because the immune attack isn't as strong.
Like a safe zone.
In a way, yes. And lymphocytes, you're right, they're a type of white blood cell, a key player in the immune system. They're the soldiers that recognize and attack foreign stuff, including transplants. But in these privileged sites, the lymphocyte response is often dampened or modified.
That's really interesting. So location matters a lot. Were there other biological plus points for fetal tissue?
Oh yes, a big one is plasticity.
Plasticity. How does that apply here?
Well, in this context, plasticity means these fetal cells haven't fully specialized yet. They're more moldable. They can adapt to their new surroundings and take on the characteristics of the cells nearby.
So they can become the right kind of cell for the job in that new location?
That's the idea. They integrate more smoothly. Plus, fetal tissue actively secretes growth factors.
Growth factors.
Yeah, these are signaling molecules. They tell the tissue itself to grow, and they encourage new blood vessels to form. That's angiogenesis.
Getting a blood supply. Crucial.
Absolutely vital for the transplant to survive and work long term. Adult tissue, in contrast, tends to grow much slower after transplant, doesn't get vascularized as well, and doesn't respond as strongly to these growth signals.
Okay, so scientifically, you can see the appeal, but then there's the source. How was this tissue actually obtained and prepared? This is where the ethics come in, right?
Yes, very much so. The primary source and the most controversial one was elective abortions. There were roughly 1.5 million annually in the U.S. around the peak research times. There were other, less common sources like spontaneous abortions, miscarriages, or ectopic pregnancies. But these often had limitations like tissue viability, potential genetic issues, or just the difficult circumstances for the parents.
And for the tissue from elective abortions, there were rules.
Extremely strict guidelines were put in place. You needed written permission, informed consent after the decision to have the abortion was made. No discussion of transplantation before that decision.
So the donation couldn't influence the abortion decision itself.
Absolutely not. The abortion procedure couldn't be changed in any way, except maybe to ensure sterility during tissue collection. Crucially, no payment was allowed for the tissue itself, and anonymity between the donor and recipient was maintained.
A lot of safeguards then. So once the tissue was collected under these rules, what was the process? How did it get ready for a patient?
It was a careful process. First, identifying the right bit of tissue. Often they only needed a really small amount, maybe around 8 cubic millimeters.
Tiny.
Yes. Then, rigorous screening for infectious diseases, hepatitis B, HIV, and others. It would be washed in sterile solutions, kept in a special buffered salt solution to maintain it. Sometimes, if more tissue is needed, it could be grown in culture.
Grown in culture. How does that work?
Basically, you put the tissue in a nutrient-rich liquid medium in a lab dish under very controlled conditions, humidity, temperature, CO2 levels, trying to mimic the body's environment to encourage cell growth.
Okay. And for longer storage.
That involved cryostorage, freezing it in liquid nitrogen. This allows long-term preservation, but not all cells freeze and thaw perfectly. Fetal neurons, for example, are quite delicate and don't always survive cryopreservation well.
Right. So challenges even in preservation. What about the actual transplant procedure for the patient? Was it major surgery?
Often it was relatively quick and sometimes surprisingly non-invasive. The tissue was frequently prepared as a suspension of individual cells.
Like a liquid.
Exactly, which meant it could often be injected using a very fine tube, a cannula, minimizing surgical trauma. They used advanced imaging, stereotaxic imaging, to guide the injection precisely.
Stereotaxic imaging. Can you explain that?
Sure. It uses things like CT scans or ultrasound to create a 3D map of the target area, usually the brain. This lets the surgeon guide the cannula with millimeter accuracy to deliver the cells exactly where they need to go.
Wow. Precision delivery?
Yes. And often, especially for brain transplants, they'd use local anesthesia. This allowed them to monitor the patient's function, speech, movement during the procedure, just to be safe.
Keeping the patient awake.
Sometimes, yes. Then antibiotics to prevent infection. Generally, recovery was pretty quick. Patients might be home in 3 days.
But risks involved.
Of course. With any brain procedure, there's a risk of bleeding, hemorrhage, or blood clots. But overall, the procedure itself was considered relatively safe.
So the big question, did it work? What kind of clinical results were actually seen?
There were some genuinely remarkable results reported, especially in Parkinson's disease.
Parkinson's. What exactly happens in Parkinson's and what symptoms were improving?
So, Parkinson's involves the loss of brain cells that produce dopamine, a key chemical for controlling movement. This leads to symptoms like slowness, stiffness, tremor, and balance problems. In some transplant patients, reports described reduced freezing spells where they suddenly can't move, improved walking, even resolution of related issues like constipation. One famous report mentioned a patient regaining the ability to whistle.
Wow, quite specific improvements.
Yes, there were also cases involving MPTP. It's a neurotoxin. Accidental exposure can cause severe Parkinson's-like symptoms very rapidly by destroying dopamine neurons. In some individuals affected by MPTP, fetal tissue transplants led to documented improvements in gait and reduced uncontrollable movements.
Okay. What about other conditions?
Type 1 diabetes was another focus.
That's an autoimmune disease, right? Where the
Yeah.
body attacks insulin producers.
Exactly. The immune system destroys the insulin-producing beta cells in the pancreas. Some patients who received transplants of fetal pancreatic tissue showed significant drops in their need for external insulin injections, suggesting the transplanted tissue was making insulin.
That's potentially life-changing.
It could be. And there was even research into in utero transplantation, trying to treat severe genetic metabolic diseases before birth.
Like Hurler syndrome. What's
Oh.
that?
Hurler syndrome is a rare genetic disorder where the body lacks a specific enzyme needed to break down certain complex sugar molecules. This leads to buildup and severe damage to organs. Transplanting fetal tissue, like liver cells, which produce enzymes, into the fetus before birth showed some success in providing that missing enzyme.
Incredible. It seems fetal tissue had applications beyond just these transplants, too, used in vaccines.
Oh, absolutely. Fetal cells were fundamental in developing the polio vaccine, the Salk vaccine, and the rubella vaccine. Huge public health impacts.
Wow.
They were also used in early AIDS research, helping scientists understand the HIV virus. And actually, attempts at fetal tissue transplantation go way back, even before the Parkinson's work. There were early unsuccessful tries for diabetes and leukemia decades ago.
So a long history. Were there any conditions where it did become a standard treatment?
Yes, one clear success was treating DiGeorge syndrome.
George syndrome.
It's a genetic disorder causing various problems, often including severe immune deficiency because the thymus gland doesn't develop properly. Transplanting fetal liver cells, which contribute to hematopoiesis.
Hematopoiesis, blood cell formation.
Right, including immune cells. Transplanting fetal liver became the accepted treatment for the severe immune deficiency in DiGeorge. Similarly, fetal thymus transplantation was used for anemic patients.
Anemic meaning born without a thymus.
Correct. So, some definite successes, but also many challenges.
Which leads us back to the shift. Why the move away from fetal tissue towards stem cells? You mentioned ethics and supply.
Exactly. The ethical debates never really went away, tied to the source from elective abortions. And practically, getting enough suitable, high-quality fetal tissue consistently was, and remains, very difficult.
Enter stem cells.
Right. Stem cells offer potential solutions to both problems. What are stem cells, fundamentally? They're cells that can develop into many different specialized cell types. And crucially, many types can be grown, expanded in the lab.
So you can make more of them.
Potentially, yes, overcoming the supply issue. And if you can use stem cells derived from the patient themselves, an autograft.
Autograft meaning using the patient's own cells.
Yes, perhaps derived from their skin or blood and reprogrammed. That could bypass both the immune rejection problem and many of the ethical concerns tied to donor tissue.
So the potential seems huge. Let's focus back on Parkinson's for a moment. You mentioned the fetal tissue trials had inconsistent results and this issue of graft-induced dyskinesia, or GID.
Yes, GID was a major setback, while the open-label trial showed some patients improved in hypokinesia.
Hypokinesia, that's the slowness of movement,
Correct, and the on-off fluctuations.
where the medication effect wears off unpredictably.
Exactly. Those sometimes improved. But other key symptoms like dyskinesia, the involuntary riding movements, and postural instability.
Balance problems, right.
Those often didn't improve as much, or results were very variable.
Even though some scans showed the grafts were working, you mentioned L-DOPA and PET scans.
Yes. L-DOPA is the standard Parkinson's medication, replacing dopamine. Some grafted patients could reduce or stop L-DOPA, and PET studies.
PET scans positron emission tomography, imaging brain activity.
Yes, using tracers like 18F-DOPA, which measures dopamine production or storage. Increases in this tracer signal suggested the grafts were alive and making dopamine, the DA transporter or DA.
Dopamine transporter, a protein on dopamine neurons.
Correct. It helps recycle dopamine. Seeing data expression in grafts years later, sometimes over a decade, showed long-term survival of these transplanted DA neurons, the dopamine neurons.
So they could survive long-term, but the results were still inconsistent, and GID occurred.
Yes. These inconsistencies plus the GID risk really led to the procedure using HFVM tissue.
HFEM, human fetal ventral mesencephalic tissue, the specific brain region used.
That's right. That approach was largely abandoned in clinical practice in favor of deep brain stimulation, or DBS.
DBS implanting electrodes in the brain.
Yes, to modulate brain circuits. It became a more reliable surgical option, though it doesn't replace lost cells.
Were there ideas on why GID happened and how to prevent it?
There were theories and strategies explored. One idea was refining the dissection of the fetal tissue, trying to be really precise to only get the dopamine neurons and avoid other cell types like serotonin neurons.
Serotonin neurons, why would they be a problem?
Serotonin neurons can actually take up LDOPA and release dopamine, but in an unregulated way, which was thought might contribute to dyskinesias.
Ah, okay. Other strategies.
Trying to distribute the dopamine neurons more evenly throughout the target area, the striatum.
The striatum, the brain region that receives dopamine signals.
Exactly. Using multiple injection sites instead of just one or two, hoping for smoother dopamine release. Also, optimizing the use of immunosuppression after the transplant was considered important for graft survival.
Which brings us to the TransEuro trial. This was a more recent attempt to do it right.
It was. The TransEuro trial was an open-label trial.
Open label, meaning everyone knew who got the treatment.
Correct. No placebo group getting sham surgery in this case, though they did have a control group from a natural history study for comparison. The goal was to see if, using optimized methods, fetal tissue transplantation could actually be a viable treatment.
But it ran into problems.
Big problems with tissue availability. They only managed to graft 11 individuals across 2 centers, Cambridge in the UK and Lund in Sweden. They used the same tissue prep, but actually different implant devices.
And the results.
The primary endpoint.
The main thing they were measuring.
Yes, the change in motor symptoms using a standard scale, the UPDRS Part 3, an off-F state when medication isn't working, measured 3 years after grafting. There was no overall significant clinical effect for the group.
Disappointing.
Very. On the plus side, they didn't see major graft-induced dyskinesis, the GIDs. But there were hints that the device or site might have made a difference.
And the PET scans? Did they show graft survival?
They used 18 fluorodopa PT imaging. It showed, on average, some improvement in dopamine uptake in 18 months in about 7 individuals. But only 1 person got back to near normal levels.
So limited success even on the imaging front.
Pretty limited. It really underscored the need for a reliable, scalable cell source like stem cells. But the trial wasn't a waste. It taught us a lot about how to run these kinds of cell therapy trials.
What kind of details from TransEuro informed future work?
Well, the specifics. Grafting happened between 2015 and 2018. Most got bilateral grafts, tissue from 3 fetuses per side, sequentially. 1 person had a unilateral graft. Everyone got 12 months of triple immunosuppression.
A serious commitment for the patients.
Absolutely. They had a control group matched for key features like age, disease severity, medication dose. They tracked lots of secondary measures too, and used PT to look at both dopamine and serotonin markers.
But ultimately not enough clinical benefit.
No. Despite some PE evidence of grafts surviving in some, the clinical improvement just wasn't significant overall.
Why do you think the benefit was so low compared to some earlier reports?
The researchers suspect it was likely due to low numbers of surviving dopamine neurons in the graft, and perhaps poor reinnervation, making connections within the putamen, part of the striatum. The actual increase in dopamine uptake measured by PT was substantially lower than in some previous studies that had reported better outcomes.
So maybe not enough healthy cells survived or integrated?
That seems likely. Limitations included the small sample size, variability in the donor tissue age, and the COVID pandemic disrupting some long-term follow-up.
But lessons learned for stem cell trials.
Definitely. The trial design itself, long run-in periods to establish baseline, careful PET monitoring, using contemporaneous controls, that's informing how the new stem cell trials are structured. And it highlighted critical factors. The dose of cells, the delivery device, maybe even the patient's age matters.
Okay, so let's pivot fully to stem cells for Parkinson's. What's the promise there?
The promise is huge. Stem cells, whether adult, embryonic, or these induced pluripotent stem cells, the iPS cells.
iPS cells, those are the reprogrammed adult cells.
Exactly. Reprogrammed from, say, skin or blood back into a stem cell state. The hope is that cells derived from these stem cells can replace the dopamine-producing cells lost in the substantia nigra.
Substantia nigra, the specific brain area where dopamine cells die in Parkinson's.
That's the one. The brain can't really replace these cells on its own. Stem cells offer a way to potentially do that.
And iPS cells have an advantage regarding rejection.
Potentially, yes. If you make iPS cells from the patient's own skin cells, then differentiate them into dopamine neurons, the resulting cells should theoretically be a perfect match for the patient's immune system. Less rejection risk, less need for immunosuppression.
That sounds ideal. So where are we with clinical trials for stem cell therapy in Parkinson's?
Things are moving, definitely. It's been over a decade of intense research. Several clinical trials are underway, but importantly, there's no approved stem cell therapy yet.
But trials are happening. What are they showing?
Yes. There's a phase 1 trial in Japan using iPS cell-derived dopamine precursors. Results published just recently, April 2025, showed it was safe over 2 years. Crucially, the transplanted cells seemed to produce dopamine, and some patients saw symptom improvements.
That sounds promising. Others?
In the U.S., a phase 1 trial using cells derived from human embryonic stem cells, the product is called Bimdam per cell, or BRTDA01, also published April 2025, showed safety over 18 months, and again, some hints of improvement in movement symptoms.
Embryonic stem cells have their own ethical considerations, though.
They do, though, different ones than fetal tissue. Another trial, STEM-PD, is running in Sweden and the UK, also transplanting stem cell-derived dopamine cells. Results expected around 2027.
Okay. Any other types of stem cells being tested?
Yes, there's a U.S. Phase 2 trial using mesenchymal stem cells, or MSCs, taken from bone marrow. Phase 1 suggested safety and maybe some anti-inflammatory effects and symptom improvement. Phase 2 results are expected in 2025, too.
So different approaches, different types of stem cells being tested.
Exactly. And ethics remain absolutely central to all these trials.
Yeah.
It's also really important for listeners to know, currently, none of these legitimate trials are recruiting participants widely from the general public. People should be very wary of clinics offering unproven stem cell cures.
Right. Stick to the rigorously controlled clinical trials.
Absolutely.
This has been a truly insightful deep dive. We've gone from the early promise and ethical complexities of fetal tissue transplantation to the current cutting edge of stem cell research for Parkinson's. It really feels like a journey, doesn't it? From those initial experiments to these incredibly sophisticated cell therapies being tested now, it's a testament to that drive for medical progress. For you, the listener, we hope this has unpacked some complex science and maybe sparked some aha moments connecting that history to the possibilities ahead. What stands out to you? What questions are still lingering? This field is changing so fast. And maybe a final thought to leave you with. As science keeps pushing these boundaries, especially in areas like cell therapy, how do we as a society make sure that the ethical thinking keeps pace with the technology? How do we ensure these powerful tools are developed and used responsibly? Something to consider. Thank you for joining us on this exploration of bio bits and bytes.
Thank you. It was a pleasure.